Blood flow to tissues relies on blood pressure, determined by two main factors: cardiac output, or the volume of blood pumped by the heart per minute, and resistance in blood vessels, like viscosity and vessel diameter. Cardiac output, in turn, depends on heart rate and stroke volume, which is the difference between end diastolic volume and end systolic volume. In shock, insufficient blood perfusion occurs due to widespread circulatory failure. The symptoms of shock represent the body's efforts to compensate for reduced tissue perfusion, which can vary based on the cause and severity. The main symptoms include hypertension, tachycardia, tachypnea, oliguria, as well as alterations in mental state such as agitation, confusion, or unresponsiveness. Hypertension is defined as blood pressure below 90/60 millimeters of mercury, tachycardia as a heart rate exceeding 100 beats per minute, tachypnea as breathing over 25 breaths per minute, and oliguria as urine output less than 400 milliliters in 24 hours. Since blood flow to tissues is dangerously low, it can cause cellular injury and organ damage. Early treatment can reverse these effects, but without proper intervention, shock can lead to irreversible multi-organ failure and death. There are four main types of shock: hypovolemic, cardiogenic, obstructive, and distributive. Distributive shock includes septic, anaphylactic, and neurogenic shock. Patients can experience combined shock with more than one type present. Regardless of type, shock presents with similar symptoms like low blood pressure, rapid heart rate, fast breathing, decreased urine output, and altered mental state. Additional features depend on the specific type of shock, such as dry mucous membranes and cold extremities in hypovolemic shock, chest pain in cardiogenic shock, fever and rigors in septic shock, and angioedema and urticaria in anaphylactic shock. The body responds differently to various types of shock. Hypovolemic shock occurs due to a sudden reduction in circulating blood volume, which can be either hemorrhagic, caused by bleeding, or non-hemorrhagic. Non-hemorrhagic hypovolemic shock results from fluid loss that is not due to bleeding, such as severe dehydration, burns, or fluid loss from the gastrointestinal tract, skin, or kidneys. This loss of fluid decreases blood volume to a level insufficient to supply the body's organs, resulting in hypovolemic shock. Losing approximately 20% of total blood volume, roughly 1 liter, can also trigger hypovolemic shock, often caused by trauma, internal bleeding, or surgical procedures. Reduced blood volume lowers the amount of blood filling the heart during relaxation or end diastolic volume, leading to a decrease in stroke volume, cardiac output, and ultimately blood pressure. To counteract low cardiac output, the body releases catecholamines like epinephrine and norepinephrine, along with ADH and angiotensin II, causing vasoconstriction to increase vascular resistance and heart rate, thus increasing cardiac output and blood pressure as a compensatory mechanism. Reduced blood volume leads to cold and clammy skin as blood carries heat to tissues. So, hypovolemic shock is a cold shock. Another indicator of insufficient tissue oxygenation in hypovolemic shock is decreased mixed venous oxygen saturation, or SVO2. SVO2 represents the oxygen content of blood that returns to the heart after meeting tissue needs. As the cardiac output decreases, the amount of oxygen delivered to the tissues goes down, and less oxygen remains in the venous blood. So, SVO2 goes down in hypovolemic shock. Another type of shock is cardiogenic shock, which occurs when the heart is unable to pump enough blood to the body's tissues. This is often seen in acute myocardial infarction or heart attack, where damaged heart muscle cells can't contract effectively, reducing stroke volume and cardiac output. Many other conditions can lead to cardiogenic shock, like cardiomyopathy, arrhythmia, or structural heart problems, as well as toxic substances like alcohol, drugs, or infections, all resulting in reduced cardiac output and blood pressure. Like in hypovolemic shock, the body releases vasoconstrictors to increase vascular resistance and to maintain blood pressure. This results in cold and clammy extremities. So cardiogenic shock is also a cold shock. The third type of shock is obstructive shock, which occurs when there's an obstruction to cardiac outflow or ventricular filling, impairing the heart's ability to pump blood effectively. One example is cardiac tamponade, where the pericardial sac fills with fluid or blood, restricting the heart's expansion during diastole and thus reducing stroke volume. This obstruction leads to decreased cardiac output and lower blood flow, similar to hypovolemic shock. Obstructive shock is caused by many other conditions like pulmonary embolism, tension, pneumothorax, constrictive pericarditis, and restrictive cardiomyopathy. Symptoms typically include cold and clammy skin, so it is also a cold shock. Like hypovolemic shock, SvO2 also decreases in both cardiogenic shock and obstructive shock, as cardiac output goes down and less oxygen is delivered to tissues. The final type of shock is distributive shock. It involves excessive arterial vasodilation and increased vascular permeability, leading to decreased blood pressure and inadequate perfusion of organs and tissues. The most common type is septic shock, caused by pathogens in the bloodstream, particularly those producing endotoxins like lipopolysaccharides from gram-negative bacteria. First, they directly damage endothelial cells, causing vasodilators like nitric oxide to be released. They also activate a complement pathway in the blood, which stimulates the mast cell to release histamine, which is also a vasodilator. The other molecules also activate immune cells like macrophages and neutrophils, which produce a large amount of pro-inflammatory cytokines like tumor necrosis factor and interleukin-1. These help the immune system to destroy invaders, but they also activate endothelial cells to release more inflammatory molecules like platelet activating factor and reactive oxygen species. All of these chemicals damage the endothelial cells and increase their vascular permeability, making the blood vessels leaky. The endothelial cells also express a procoagulant called tissue factor, which increases blood coagulation. In addition, anticoagulants seem to be often depleted during sepsis, leading to the net increase in coagulation and clotting in the microvasculature. Clotting in the blood vessel further decreases perfusion. As the blood flow in the peripheral blood vessels increases, the skin becomes warm and flushed. So, distributive shock is a kind of warm shock. The overall combined effect of widespread vasodilation, increased vascular permeability, and microvascular blood clotting all contribute to the decreased perfusion of blood to vital organs. Widespread vasodilation means very little vascular resistance, and blood can't get a chance to unload as much oxygen as it passes through the vasculature. It gets back to the right side of the heart with more leftover oxygen. As opposed to cardiogenic and hypovolemic shock, SvO2 can be normal or even increased in septic shock. Septic shock can result from various infections, including both gram-negative and gram-positive bacteria, virus, fungus, and parasites, with immunosuppressed patients being more vulnerable. The other subtypes of distributive shock include anaphylactic shock and neurogenic shock. Anaphylactic shock occurs due to a severe allergic reaction where an allergen enters the bloodstream, prompting an exaggerated immune response. This leads to a massive release of histamine, causing systemic vasodilation, bronchial constriction, and tongue swelling. Neurogenic shock is caused by severe traumatic brain or spinal cord injury, which compromises the sympathetic nervous system. This results in an unopposed parasympathetic response, leading to decreased vascular resistance and vasodilation. Neurogenic shock typically occurs with spinal cord injuries above the level of T6. Treatment for shock varies based on the underlying cause, with the primary aim being to stabilize blood pressure to ensure adequate perfusion of vital organs. This typically involves fluid replacement and medications to increase heart contractility and induce vasoconstriction. Additionally, supplemental oxygen may be necessary, and airway protection measures such as intubation may be required to support breathing and oxygenation.